Hi, today I'm going to discuss the new guidelines for nutrition therapy for adults with diabetes or prediabetes. This is a consensus report, and I'm going to discuss some of the findings in the report, but I also want to urge you to read it, because more than any other guideline on nutrition, they really go through all of the different studies and discuss all of the conclusions, which actually make the data that's available make somewhat more sense. So first of all, we know that medical nutrition therapy is really effective at lowering A1Cs if people follow the advice. So it can work as well as medication, but the problem is getting people to change their habits and then to stick long-term to a new way of eating. And I don't like to call this diet anymore. What we call it is a lifestyle change, a form of eating, a way of existing that is healthier than prior patterns. It is recommended that adults living with either type 1 or type 2 diabetes have individualized diabetes-focused medical nutrition therapy, both at diagnosis and then as needed throughout life. And I think people really do need refreshers, and I think it helps to encourage them to go back to see their registered dietitian as they live their life with diabetes. Now, in general, it's recommended that the focused medical nutrition therapy be given by a registered dietitian who has expertise in this field, particularly with regards to patients with diabetes. It's also recommended that patients with prediabetes and who are overweight and or obese to lifestyle interventions such as the Diabetes Prevention Program, which are becoming increasingly more available to our patients. The primary goals of nutrition therapy are, frankly, to promote and support healthful eating patterns, emphasizing a variety of nutrient-dense foods in appropriate portion sizes. So, healthy foods eaten in the right amounts, and this will lead to improvements in A1C, blood pressure, and cholesterol levels. A second and very important goal is to maintain the pleasure of eating for patients by giving people positive messages about healthy food choices and to provide practical tools for day-to-day meal planning. Evidence suggests that there is not an ideal percentage of calories from carbohydrate, protein, and fat, but rather macronutrient distribution should be based on individualized needs using current eating patterns, preferences, and metabolic goals. A key strategy to achieving this really means that patients undergo an assessment of what they're currently eating, followed by individualized guidance on self-monitoring of carbohydrate intake, optimizing meal timing and food choices, along with medication and physical activity. In general, there are a variety of eating patterns that are acceptable for the management of diabetes. There isn't just one way, but frankly, the best way is the way that the patient will adhere to. What's most important is that we focus on these key patterns. One, emphasizing non-starchy vegetables, but vegetables in general are good for you. Secondly, minimize use of added sugars and refined grains. And third, choose whole foods over highly processed foods. So this is pretty simple. Healthy, non-starchy vegetables, minimize sugars, less refined grains, less processed foods, and whole foods are better than others. Reducing overall carbohydrate intake has demonstrated the most evidence for improving glucose control. Reducing overall carbohydrate intake with low or very low carbohydrate eating plans is in fact a viable approach for the management of patients with diabetes. The most robust research related to eating patterns for prediabetes or type 2 diabetes prevention are Mediterranean-style low-fat or low-carbohydrate eating plans. Now, there's a whole bunch of different eating plans or patterns discussed in this consensus statement. They include the Mediterranean-style eating pattern, vegetarian or vegan eating patterns, low-fat eating patterns, very low-fat such as Ornish or Prediabetes eating patterns, low-carbohydrate or very low-carbohydrate eating patterns, the DASH diet, paleo eating patterns, or intermittent fasting. So really there's information here on all of these different patterns, and basically all of these are acceptable as long as the patients are getting the right distribution of macro and micronutrients to stay healthy and achieve their target goals. In individuals with type 1 diabetes, a very low carbohydrate eating pattern may have potential benefits, but we don't have clinical trials of sufficient size and duration to confirm the findings from prior smaller studies. Sugar-sweetened beverages are not a good thing. We all know this. They're associated with an increased risk of type 2 diabetes, weight gain, heart disease, kidney disease, non-alcoholic fatty liver disease, and tooth decay. So sugar-sweetened beverages, not a good idea. We all know that. On the other hand, what we want patients to do is consume water as much as they can as a replacement for these sugar-sweetened beverages. There are sugar substitutes which are less bad than the sugar-sweetened beverages, but not really considered good. So patients should avoid as much as they can compensating with these sugar-sweet substitutes because they're going to potentially increase caloric intake from other food sources. Other considerations are that overall it is not recommended that patients take vitamins or minerals unless they're proven deficient, but there needs to be a consideration of patients having additional vitamin B12 supplementation if they're on metformin, so it's recommended that vitamin B12 status be assessed annually in patients who take metformin. In terms of fat and reducing cardiovascular disease risk, it is recommended that regardless of whether it's a high-fat or low-fat diet, that saturated fat should be kept to less than 10% of the overall diet, and that if patients are adding in more fat in terms of increasing the fat in the diet, it should be unsaturated or monosaturated fat. In terms of sodium intake, basically the recommendations are the same as for the general population, so our patients with diabetes in general do not need sodium restriction. And interestingly to me, it is no longer recommended that we reduce protein intake in patients with chronic kidney disease. In fact, it states that protein intake in CKD patients doesn't need any restriction compared to what we recommend for the general population. However, those with macroalbuminuria may benefit from switching to more soy-based protein than animal-based protein to reduce their cardiovascular disease risk. In conclusion, people with diabetes should work with a registered dietitian in order to create an appropriate and acceptable way of eating as they live with their diabetes. I think it's important to realize there's no one way to do this, and in fact, the way patients eat may change over time. I'm not a huge fan of fads, but I think there are many different healthy eating approaches, and I think with the right help and advice, it's possible to create an eating plan that will work for most of your patients with diabetes. Thank you.